Hello, I'm Dr. Jane Wong. I'm an immunology and allergy specialist from Queen Mary Hospital, and I'm delighted today to be given the opportunity to talk about our study from the Hong Kong Drug Allergy Labeling Initiative, or Hong Kong DADI. And this was a multi-center, territory-wide implementation of penicillin allergy delabeling by non-allergists. So first of all, I'd like to start off with a bit of epidemiology and why we need to be so invested in beta-lactam allergies. And this was a study that was performed a few years back looking at the prevalence and incidence of beta-lactam antibiotic allergies. And we were able to capture most of Hong Kong. So more than 7.5 million people in the general population were included in this study. And if you look at the numbers, that equated to 1 in 50 people who had a beta-lactam allergy. And if you look at the inpatient cohort, even more, 1 in 20. And the incidence is what is most worrying. So every year, we are faced with more than 8,000 new beta-lactam allergies created every year. So that is an ongoing and growing problem that we need to tackle. And why should we target beta-lactam allergies out of all the drug allergy labels? First, it's prevalent. Second, beta-lactams or penicillins are used in many first-line treatments of bacterial infections. And the consequence of an incorrect beta-lactam allergy would mean that the physician would have to use a non-beta-lactam antibiotic, and this would develop MDROs, it would prolong hospitalization, increase healthcare costs, and on many times it is ineffective, and it also increases the use of big gun broad spectrum antibiotics. And on the right is a table looking at the non-beta-lactam or the broad spectrum antibiotics in the orange, and the prices of these are exponentially higher than the first-line beta-lactam antibiotics. And so what happens when a patient has penicillin allergy and is referred to an allergist? What do we do? So in the traditional pathway, we see the patient in our clinic. We take a comprehensive history. Then we decide what tests they would do, for example, skin tests or drug provocation tests. And then the patient would come back at follow-up for further counseling or further tests if required. And as you can see, this is an arduous patient journey. The patient has to come back, at least 3 times. And, our waiting time is very long. And so we also did a study previously looking at our delabeling service in our cluster. And if you perform proper allergy workup, more than 90% of the allergy labels are in fact false. And because this was a study looking at a nurse-led protocol, we found that a nurse-led program was equally as effective and as safe as an allergist seeing this patient alone. And if you look at the breakdown, nurse-led evaluation led to an even higher rate of future penicillin use after delabeling and mitigated need for unnecessary skin testing. So nurses play a big role in our penicillin allergy delabeling. And so this comes to our problem. There is a growing demand. There's a growing number of penicillin allergies. So is the answer to have more allergists? There are only 2 adult INA specialists under the HA. Should we create more training centers? Okay, at the moment, Hong Kong West Cluster is the only accredited training center. Or should we demand for more service infrastructure? And again, we are the only cluster with INA services. And so the question that comes into mind, that is a quicker solution. We don't have to wait for the 7 years or 8 years to train a new allergist, is whether non-allergists can play a role in penicillin allergy testing, especially in low-risk cases, which is the majority of cases. So that was the reason why we created our Hong Kong Drug Allergy Delabeling Initiative group, or Hong Kong DADI group. And we came together. This was a bunch of allergists, immunopathologists, and also other physicians, like internal medicine physicians, microbiologists, infectious disease specialists. And we came together to write a set of consensus statements to see how we can perform penicillin allergy by a non-allergist safely and also effectively, and to help mitigate this growing problem and mitigate the need for all penicillin allergics to be referred to a allergy center. And so this is the hub and spoke model. A hub and spoke is what the centerpiece in a wheel. And the hub would, of course, be our Hong Kong West cluster, where we have an allergist, and the other 6 clusters would be the spoke. And the idea of this was that all centers can see low-risk penicillin allergies, which was the majority. But if we triage patients with maybe a medium risk or a high risk, then we can refer to the hub, and this would be an integrated model where there's back and forth communication between the hub and spoke. And so we created many training sessions to talk about how to take a proper drug allergy label, how to triage cases into low, medium, or high risk. We created many patient pamphlets, designed questionnaires in order to set this initiative off. And so this study was to look at the implementation and outcomes of creating this Hong Kong Daddy in our hub and spoke model. So in the study, we had 3 spoke centers plus our hub itself. And all patients were required to go through this triage system or risk stratification system in this kind of traffic light system. So if the patient belonged to a low risk and this is a low risk of having a genuine penicillin allergies, then the workup will be done at the spoke or the hub, depending on where the patient was referred to. If the patient belonged to a medium risk, then this would warrant a review by the HK Daddy group, which was performed, which we had every quarterly. And if the patient belonged to a high risk, for example, had an anaphylaxis, or they had some Stephen Johnson, DRESS, AJAP, etc., then this patient would be referred directly to the hub. And so these are the baseline characteristics. As you can see in both the allergy and non-allergy cohort, most of the characteristics were the same, apart from female, and also the number of concomitant drug allergies, which were more in the allergist cohort. As you can see, we have around a third of patients in this cohort that were evaluated by the hub and 2/3 by the spoke. And if you looked at all the patients, of the 214 patients that were evaluated, 93.9% of penicillin allergy labels were delabeled. And with proper triaging protocols, there were very few patients with positive skin tests or positive drug challenges, and all drug challenges had minor reactions only. And there was no difference in the delabeling rates, skin test positivity, or challenge positive tests. And if you look at the quality of life scores before and after drug evaluation, it improved in both the allergist and the non-allergist cohort. It reduced waiting time from if the patient is referred to a spoke, this would take half a month versus the more than 1 year waiting time at the hub. And it didn't matter whether the patient was, regardless of the sex, or whether the patient had concomitant drug allergies. And also, allergists required fewer consultations with a higher rate of completing evaluations within a single visit. So the conclusion is that with proper training and support, non-allergists can independently conduct penicillin allergy evaluation among low-risk individuals. And compared to allergists, evaluation of low-risk penicillin allergy by non-allergists can be comparably effective, safe, and have an impactful quality of life. So for future studies which are ongoing, we can look at long-term outcomes of penicillin allergy delabeling. We can look at hospitalization rates, MDROs, use of second-line antibiotics, longevity of antibiotic delabeling, socioeconomic costs, and quality of life. We can look at the role of skin tests in low-risk cases versus direct oral challenge. The role of interdisciplinary care, for example, pharmacists in drug allergy delabeling, the role of hub and spoke model in a primary or secondary setting, and also the role of a hub and spoke model in other non-penicillin drugs. And these are all future studies that are currently ongoing. I'd like to give acknowledgements to everyone in the HK Daddy group, as well as our team at Queen Mary and also Grantham Hospital. Thank you very much.